Bulimia nervosa is characterized by recurrent episodes of binge eating. It's true that a binge involves eating an amount of food that is definitely larger than what most individuals would eat in a similar period of time, but that's very subjective and somewhat judgmental. What's most important in terms of making a binge is the sense of lack of control. We all may overeat at certain times, like at buffets at conferences, holidays, or birthdays, but we don't have that loss of control that is required for it to be considered a binge. It's the feeling that one just cannot stop eating or control what and how much one is eating. And along with these recurrent episodes of binge eating, there are recurrent inappropriate compensatory behaviors, usually purging behaviors. Now, purging technically means self-induced vomiting, misuse of laxatives or diuretics. The use of diet pills or stimulants, excessive exercise, or indeed compensatory behaviors, but they're technically not purging behaviors. In addition, self-evaluation is unduly influenced by body size or shape, and the disorder does not occur exclusively during episodes of anorexia nervosa. And then similarly to anorexia nervosa, there's a partial and full remission specification, and then the severity specification is based on the number of episodes per week, from just requiring 1 time per week in mild cases to 14 or more times per week in extreme cases. I've seen many cases of bulimia nervosa in which the person is literally binging and vomiting all day long every day. They tend to go from one fast food restaurant to another, stopping in the bathrooms to self-induced vomit. Clinicians should have a high index of suspicion about the presence of bulimia nervosa, especially in women who manifest high levels of psychiatric comorbidity, suicidality, and electrolyte disturbances. The history of pharmacological treatments that have been studied goes back to the 1980s when a variety of antidepressants, whether tricyclic antidepressants, MAO inhibitor antidepressants, or SRIs, serotonin reuptake inhibitors, have been found to be helpful in the acute treatment of bulimia nervosa. Fluoxetine has also been shown to be effective in the maintenance treatment of bulimia nervosa. Please note that although bupropion was found to be superior to placebo, there was an inordinately higher risk of grand mal seizures, and there is a black box warning against the use of bupropion in eating disorders. I would strongly recommend do not use bupropion in patients with eating disorders. You may very well have patients come to you on bupropion, but when they come to me, I taper them off of it. I explain why. Because medico-legally, you don't stand a prayer if something would happen if that person were driving, for example, and had a seizure, and you've been prescribing bupropion. Bad news. There are plenty of other treatments that can be helpful besides bupropion. There is one small study with trazodone, but it's not something that I use given its side effects, especially at higher doses. There is evidence for topiramate, also difficult to tolerate, and there is the antiemetic I mentioned previously, ondansetron or Zofran. I'm going to show you the results of all of these studies. The key points here are objective binge eating is defined by not only eating a large amount of food in a discrete period of time, but most importantly, a subjective sense of lack of control over eating. The presence of compensatory behavior distinguishes bulimia nervosa from binge eating disorder. The mainstay of treatment of bulimia nervosa are antidepressants, especially fluoxetine at higher doses, for example, 60 to 80 milligrams per day. But other agents, such as topiramate and ondansetron, have also been found effective.